Good morning, ladies and gentlemen. A warm welcome also from my side. Being in Vienna, being Viennese, I thought this is the city of Sigmund Freud. And thus, my presentation is a little bit based on psychology, on the cognitive errors you may make using MRI. But let's start with the definition of a pitfall. What is a pitfall? An unapparent source of trouble or danger, a hidden hazard, any trap or danger for the unwary, and pit is the old English word for trap.
Sorry, the presentation is not left.
Oh, it's not working. I'm sorry.
Can I just go here?
Okay, here you have it. What does a pitfall mean for MD? Well, a misinterpretation. And your misinterpretation may have consequences for patient management. You already heard about the perceptual errors of interpretation, a missed pathology present on an image leading to a false negative interpretation. Why does this happen? Well, because perhaps there is no knowledge of the respective imaging presentation of the pathology, or you are only tired. Cognitive error of interpretation, a scene structure is misinterpreted, and this may be a normal structure, an artifact, a pathology, or a wrong pathology, and the reason is the same: you don't know what you are looking at. Do you know perhaps that cognitive factors contribute to a diagnostic error in about 3/4 of cases? And there is a replicable pattern in perceptual distortion, inaccurate judgment, and illogical interpretation. That happens all the time, and it may be triggered by a certain situation, of course. And the psychological factors leading to this misinterpretation are mainly these four. And what they are, I will come to that during my presentation. But now let's start with the first case. This is a 12-year-old child. It's a follow-up after cerebral germ cell tumor, and now there is an increase in tumor markers. This was reported to be normal. But if you look closely on these two images, something is not quite normal. Here you have nodules in the course of the 9th cranial nerve, and here you have a nodule on the parasagittal slice again, and a follow-up 1 month after intrathecal therapy did not show these lesions anymore. So, now the first question: what is incorrect? Leptomeningeal metastasis may cause a pathological cell count in CSF, enhance after contrast media, not enhance after contrast media, may always be proved morphologically, and may lead to an increase in ventricular width. Please vote. Can we have the voting? I think the voting does not work. Oh, yes, it does. Yes, D is completely correct. They may not always be proved morphologically. Sometimes only the CSF shows signs, sometimes only the MR, so usually it's good to perform both. Why was the radiologist biased? Well, there were no clinical symptoms. Tumor markers are not always reliable. There was no enhancement, and bilateral symmetrical lesions always suggest normal structures. But, and there is a but, meningeal metastasis may enhance delayed or not at all, and there you have an example of a small frontal metastasis on T2, T1, and here T2, T1 after contrast, and here you have a delayed sequence. And you see here is at least slight enhancement. So usually, if you look for meningeal metastasis, do a delayed sequence. Now, this was an example of so-called premature closure. What is premature closure? It's the tendency to accept the diagnosis before full verification. In that case, the radiologist accepted there was a negative scan because he was biased, as I showed before. What can you do as a corrective strategy? Try to get more information. In this case, were there clinical symptoms? Because cranial nerves almost always cause clinical symptoms, and with suspect meningeal involvement, always review the cranial nerves. So, next thing, flare hyperintensity of CSF spaces. Happens all the time. And here is my next question. A flare hyperintensity of CSF spaces is not a consequence of a flow artifact, hemorrhage, calcification, proteinaceous material, infectious or carcinomatous meningitis. Please vote. Yes, calcification, of course, is the correct answer. And let's go a little bit into some cases with flare hyperintensity of CSF spaces. This is a 27-year-old, it's a female because she's pregnant. Migraine has been known already before pregnancy, and now there is an acute onset of headaches. Here we have our flare hyperintensity. SWI does not help really much, also not the T1s. There are some more sequences, even a T2 star was attempted. And here on the coronal T2, you might detect some widening of the ventricles that are not normal at 27 years. So, which MR sequence would be necessary with these findings? MR angiography, inversion recovery, perfusion, diffusion weighted sequence, or contrast enhanced T1. Please vote. Interesting. So what we did is the MR angiography showing an aneurysm, and the patient underwent surgery, and here you have the follow-up. This was the first examination with flare, and here you have no hyperintensity anymore. What has happened in the misdiagnosis of the patient? So-called search satisfaction. What does that mean? It's the tendency to stop a search for an abnormality once a diagnosis evaluated as likely is found. So what did the radiologist think? Well, pregnant women are prone to have headaches. And then there was a history of previous migraine. And as you know, probably, in more than 50% of pregnant women, when they had migraine before, this aggravates during pregnancy. So the radiologist accepted there was a normal MR because the usual findings were already excluded. There was no press and no venous thrombosis. However, you never should be satisfied with such a diagnosis because there are a lot of other possibilities causing headache in pregnancy, and you really should try to rule out everything. So the corrective strategy for flare hyperintensity of CSF spaces is, in case of a suspect flow artifact, get other planes or sequences. In case of hemorrhage, CT would be nice, but because she was pregnant, she didn't want to have a CT. You could do it. It would not be dangerous. And when you suspect proteinaceous material, infection, or carcinomatous meningitis, give contrast media. And I will show you some examples. This is a 24-year-old with increasing headache, vomiting, fever, and CSF shows bacterial meningitis. You have the flare sequence, and you see here in this hemisphere the CSF spaces are not as dark as they should be. You do a diffusion. I don't know whether this helps you, but this is T1 after contrast, and here you see some enhancement of the CSF spaces. Or here, a granulomatosis vagina is known in this patient. Now she has headache and vomiting. And now look at this sequence. You might think this is T2 because there is such a brightness of the insular cisterns. But if you look into the ventricles, they are black. And the technologists swore this was a flare. And it also looked like a flare from the parameters. So this is a flare sequence. So this is not normal. If you go to T1, you have some brightness here. And T1 with contrast media, especially the delayed sequence, shows some enhancement here. And this is the follow-up after 6 months after therapy, and this looks quite normal. Here we have another case. A melanoma was known. Now, headache, facial pain, and vomiting. This is the flare showing bright sulcur in the cerebellum. T1 is not really very helpful, but look at the trigeminal nerve. It looks thick, and you have an enhancement of the CSF spaces and of the trigeminal nerve. Probably that's the cause of the facial pain in this patient. So, now my question. Pathologies involving the subarachnoid space or the arachnoids will not lead to a delayed enhancement of leptomeninges, impairment of CSF drainage, visible intraparenchymal diffusion abnormalities, hyperintensity of sulci on flare images, and or abnormal cells in case of lumbar puncture. Please vote. Yes, of course there are sometimes, and there are papers that you can measure diffusion-weighted abnormalities, but it will not help you in all-day clinical assessment. So this is one of the rare conditions where diffusion-weighted imaging might not be helpful. So, the next case. We have a 32-year-old with transient double vision, occipital headache, smoker, on birth control, and I could also say it was in summer. So what was seen? A structure was seen here. Here, after contrast enhancement, here you see this sparing after contrast enhancement. And this is the venous angiography. So, my question, the structure marked with an arrow corresponds to acute venous thrombosis, non-recent venous thrombosis, calcification, bachionic granulation, or an early stage of a brain abscess. Please vote. Oh, sorry, yes, of course. Here, this one helps, I think. But you made the diagnosis anyway. This is, of course, a bachionic granulation. And now we have difficulties because with this history, the radiologist thought of venous thrombosis and he diagnosed it as venous thrombosis. But now we don't have a diagnosis, we have a normal MRI. And of course the patient came again because she still had occipital headache. So there was a new referral to a different radiologist, and that is what was seen. So this is coronal T2. This is axial T2 at the level of the cervical spine. This is angiography, and this is also an image of angiography, the raw data. Please look at this and then tell me your diagnosis. What is the correct diagnosis? Is it acute venous thrombosis, non-recent venous thrombosis, thromboembolic occlusion of the right vertebral artery, dissection, or a hypoplastic right vertebral artery? While you are voting, I'm going back to this image. Yes, the diagnosis is right. This is, of course, a dissection of the right vertebral artery, and I can prove it because 3 months later, as you can see, there was recanalization. So, already 15 years ago, a paper was written telling that more than 50% of the patients with vertebrobasilar artery dissection have a headache, and they only might have headache and no other neurological complaints, because such a condition, and this is the conclusion of the paper, may present without any or with only minor symptoms. And that is known for 15 years. Already 15 years later, this year, this condition was included into the international classification of headache disorders by the International Headache Society, and it is now headache type 3 beta. This type 3 beta is the type of headache you might get with vertebrobasilar or carotid artery dissection, because this headache that may also be localized is a very frequent clinical finding in such a condition. So what has happened? Anchoring. What is anchoring? Relying on an initial impression and failing to adjust this impression in light of subsequent information. Because what you could do is to avoid early guesses. So if such a patient comes and you don't find anything, look, ask somebody else, seek to disprove your initial diagnosis, especially if you couldn't find anything abnormal, and consider the diagnosis, and of course, get a second opinion if available. And what also has happened was a framing bias. What is framing? Frame is being strongly influenced by subtle ways in which a problem is worded or framed. Well, the history of the patient, as we said already, suggested there was venous thrombosis. And also in other situations, it depends what cases you have seen recently, what you have read recently, whether you are a pediatric neurologist or neuroradiologist, or whether you have some other specialty. All this might influence and bias your diagnosis of a case. What is the corrective strategy here? Reconsider your own diagnosis. If the clinical course suggests something else, and always think of differentials, there are almost no pictures that are really pathognomonic for a certain condition. Well, Let's move to the next case. A 26-year-old develops a right-side hemiparesis and speech problems within weeks. Diffusion-weighted image and the ADC, flare, and T1 after contrast and spectroscopy. Long echo time at 1.5. We have a choline-creatine misrelationship with the high choline. Also the NAA seems low, and we have a lactate. Well, because of the report of the radiologist, the patient came back after 1 week for a pre-bioptic scan. The morphology was unchanged. This is the spectroscopy that you already saw, and this is the spectroscopy at follow-up. And what you can see here is the NAA has recovered. The misrelationship between choline creatine and choline NAA is not that bad anymore. Now, please, what is your diagnosis? What is most likely? Glioblastoma, demyelination, abscess, necrotic metastasis, or hemorrhage in resolution? I give you the images again. Please vote now. Yes, you made the diagnosis again. This is demyelination. And you see ring lesions can happen with any pathology. But why was the radiologist biased here? It was a single lesion. Usually demyelinating lesions are not single lesions. There was a ring-like enhancement. There was an edema, a high choline creatine peak and a peak in the lactate lipid region, and a fast onset of some symptoms. But, of course, and you know it very well, the age of the patient is very young, and you all are aware, obviously, of giant lesions, and the ring was incomplete. So, it was again an example of premature closure. The diagnosis was done before full verification. And what I already said, the corrective strategy here is always generate a differential diagnosis and perhaps use checklists. So, but of course I show you another giant lesion. Here you see a really incomplete ring, but here it's easier because there are other lesions too. And this is just an example of a ring-shaped glioblastoma with the correspondent spectroscopy. And here you see the image that really has a closed ring and some more enhancement. And of course, if you have some ring-like enhancing structures, you might use diffusion-weighted images at least for the help for the differential between a tumor or radiation necrosis and an abscess. As you know, abscess formations are very bright on diffusion and dark on ADC, and it's the other way around with tumors. And regarding the abscess, perhaps you have another help, and this help comes from spectroscopy, because here you see some peaks that look rather strange because they are around the region of lactate, but they also have other directions. And if you see amino acids in such a lesion, then you know it's an abscess. Unfortunately, it depends on the stage of the abscess whether you see this or just a huge lactate and very low other peaks. Well, I have the feeling all the cases I showed were not difficult enough. So I just changed in my head. Unfortunately, I have a more difficult here because there was a referral to prenatal MRI because of suspect agenesis of the corpus callosum in gestation week 34. What you see here are 3 planes of T2-weighted images, and they are not of good quality. You don't have to tell me that, but I know. Here is really a very thin corpus callosum. The baby was born in gestation week 38 and showed a reduced muscle tone? Well, we saw the same thing we already saw before in gestation week 34. And then, this is again the image I just showed to you. There was at 6 months a sudden onset of breathing problems after infection. And this is what it looked now with 6 months. Well, there is still the same finding of the small corpus callosum, but there are symmetrical lesions in the substantia nigra, the lamina quadrigemina, the central tegmental tract, and the subthalamic nucleus, and there is also a little lactate peak. This is the postmortem finding, and this was a Lee syndrome, a mitochondrial disorder. And now this is a complicated case, and as a consequence, also my questions are rather complicated. Let's summarize the history. Again, this was the history, and this is the questioning. What is true here? A, the clinical presentation is due to the malformation. The malformation and the lesions are of different origin. Mitochondrial defects may be accompanied by commissural agenesis. The corpus callosum hypogenesis is an accidental finding, and the lesions are atypical for Lee's syndrome. Please vote now, and I go back to the pictures so that you can look at that. Oh, nice. There we have several choices. Well, the correct answer is mitochondrial defects may be accompanied by commissural agenesis. This is not only true for mitochondrial diseases, but also for other metabolic diseases, for instance, non-ketotic hyperglycemia or such things. That means, what does it mean? If you have a newborn or a fetus with a commissural agenesis or a hypoplasia of the corpus callosum, think that this might just be the peak of the iceberg and not the real diagnosis. There are really some metabolic diseases. Here is a good publication that may be accompanied by malformations. So, what has happened? Anchoring. The radiologist relied on the initial expression he thought the diagnosis was made. It is corpus callosum hypogenesis. What is the corrective strategy? Again, avoid early guesses. Try to disprove your diagnosis or extend your diagnosis, reconsider it, and get a second opinion. Of course, with the new clinical signs of the baby, you should really reconsider what you have found initially. Now, this is another easy case, 50-year-old with headache after arthroscopic surgery of the knee. Now you have to imagine the situation, night shift, another headache patient, and coming from the surgery department, not from neurology, not from the acute ward. It's just after knee surgery, so there will be nothing. Well, unfortunately, there is something. You see here bilateral hygromas, and on the flare sequence they are bright. Here T1, T2, and there is an enhancement of the dura. If you look at the tonsils, they could be deeper. They are not really deep yet, because perhaps that was why this was overlooked, because this is, of course, intracranial hypotension syndrome caused by a CSF leak. Why was the diagnosis not made? Because the informations were misleading, and there was epidural anesthesia had been performed before, and the dura had a leak afterwards, and the radiologist did not talk to the patient. Well, how often do we talk to patients? It's because the history would here be that the headache would be worse in upright position than in lying down. It's, of course, again, an example of framing bias or effect. The radiologist really thought nothing would be found, and this is recommended, this corrective strategy, by this paper. I don't think this is good. I think seek more information from the clinician or the patient, him or herself would be better. Now, this is my last case, and I hope this is difficult enough for you. This is a newborn with seizures. Well, the radiologist saw the right hemisphere is larger. I put a question mark here because what is really large here is the ventricle. The ipsilateral cortex is abnormal, yes. The ipsilateral white matter is abnormal, yes. There is intraventricular hemorrhage, yes, there is. And there is a large ipsilateral glomus. So the first diagnosis was hemimegalencephaly. Well, let's compare it with proven cases of hemimegalencephaly. Here, for instance, we have a 4-month-old with abnormal myelination, as this is a feature of hemimegalencephaly, and this hemisphere is really big. Of course, also the ipsilateral ventricle is always a little bit wider than on the normal side, but not as much as in this case. Then we got the CT, and the CT clearly shows calcification. Now you are asking me, why isn't she showing us a bone window? Well, because fine dispersed calcification would not show up there. You would have to play around with the window a lot, as Luc told you before. So this is calcification. Then we have a follow-up 8 weeks later. Here you see the original image, and here you see already some atrophy. Is this in keeping with hemimegalencephaly? And if not, what would you think? Well, usually, I have to tell you, the diagnosis of hemimegalencephaly is done in utero because you see the big hemisphere here and also the pathological lamination of the brain parenchyma compared to the other side. And here you have the pathological proof. So this is rather an early diagnosis. But there is, for instance, Sturge-Weber syndrome. Here we have a 6-month-old child. Here you have really a shrunken part of the hemisphere, and there is also pathological signals in the underlying white matter. You have this large glomus, and of course you have some enhancement here of the arachnoids. And this would be the CT scan, now showing huge calcifications. So what is a Sturge-Weber syndrome? It's a phacomatosis. You know there is a port wine stain along the trigeminal boundaries. However, sometimes the port wine stain is not there at birth, and sometimes it also never happens. In about 20% of Sturge-Weber syndromes, there is no port wine stain. Usually they have seizures before the first year of life, unilateral visual impairment, and retardation. Here you have another case. Also here you can see the glomus and the atrophy of the hemisphere. So, which radiological feature is not found in hemimegalencephaly? Calcification, abnormal cortical folding, abnormal signals of the white matter, different size of the hemispheres, and a presentation already in the 2nd trimester. Please vote. You want to see pictures again? No, I think everything was clear here. Yes. Also, this question was too easy for you. I hope in spite of that, you enjoyed the cases because calcification is not found in hemimegalencephaly. Perhaps it might be new for you that Sturge-Weber syndrome may manifest already at birth in that fashion and may have also anomalies of cortical folding and signals that are bright on T1, and they suggest pathological myelination, but it is, in fact, calcification. So, what happened? Availability bias. That means the diagnosis that comes in mind first is your diagnosis, and you cannot think of any other. If this is the case, please go to the literature, obtain more information by imaging study or other modalities, ask somebody. Well, this was the last case I would like you to take home. Use a systematic approach from skull to the ventricles, from skull base to calvaria, then you will not miss anything. Get additional information anywhere you can get it and provide a structured report to help the clinicians. I hope you enjoyed at least some of the cases. Thank you very much for your kind attention.